Okay. Let me at the outset thank the AOS, the ARSI, and the ISRS for this wonderful webinar, and wonderful opportunity as well. Toric IOLs, what can go wrong? That's what I'm going to talk in the next 5 or 6 minutes. The keys to the refractive cataract surgery is increase the refractive accuracy, number one. Number two, decrease the complications. Number three, choose the best visual quality IOLs. Number four, exceed the patient expectations, which is under promise and over deliver. Dr. Maipal has covered most of the topics, which made my life a little bit easier, but let me take you through some case scenarios, about 7 or 8 case scenarios in the next few minutes. The case one is a 64-year-old female who underwent a toric T4. The preoperative astigmatism is 1.75, and the postoperative is also 2 diopters, the same, more or less the same. The reason why was there was a wrong data feeding. Okay, case was done about 15 years back when we relied on the manual keratometer before the advent of the optical biometers. And the manual feeding, wherein the OD keratometer was fed for the OS values, and the OS keratometer values were fed for the OD. And because of that, the IOL was placed at 177 degrees instead of 86. I need to go in and rotate this lens and became all right. Case 2, you can see a restored toric lens. On the right eye, the patient had an uneventful surgery with an excellent postoperative visual acuity of 6.6 and 6. The left eye, the restored toric lens, the postoperative refraction of about plus 0.5 with minus 3 cylinder Rhexis 155. What went wrong in this lens in this particular case? Again, the manual keratometry and the IOL master gives slightly different values as far as the H and V are concerned. The manual keratometry gives the horizontal first and the vertical second, whereas the IOL master, the lens chart, gives the vertical first and the horizontal second. So the optometrist got confused between the two and put the keratometry values were actually interchanged when fed into the Accusoft toric calculator. The horizontal value was put for the vertical value was put for the horizontal, and because of that, the axis of location was 56 degrees. The actual axis of location was actually 135 degrees. I identified this in the initial postoperative period within a few days, and then opened up the bag with the cohesive viscoelastic and tried to rotate this particular the Accusoft toric lens into the original position of 140 degrees from 56 degrees, and the patient did very well. Residual astigmatism, I think Maipal has emphasized this very, very important point. The patient was lying down. How to avoid axis marking also always be done with the patient in the sitting position. In this particular patient, the Callisto did not work. The Callisto is a markerless system which I use. So I did the when the patient lying down. Actually, when the Callisto does not work, it's actually a good idea to make the patient sit up and do the marking again, because that will take care of the problem to a large extent. And this probably, the residual astigmatism was probably because of the supine the supine position, and because of that there is a residual astigmatism, and because of the wrong marking as well. Number 4, the capsular Rhexis. I think Maipal has beautifully mentioned that the ideal size of the capsular Rhexis in the toric lens will be about 5 millimeter. Larger capsular Rhexis size, for example, this patient had a larger capsular Rhexis size of about 5.55 or 5.75, and because of that, there was a large Rhexis. There was a forward movement of the IOL, and postoperative refraction of about minus 1.5 spherical. When the IOL moves forward, there will be a myopic shift. When the IOL moves backward, there will be an hyperopic shift. So this is one of the patient postoperative period wherein you can see that the IOL moved forward, and because of the larger capsular Rhexis size. Again, smaller capsular Rhexis is also a big problem because they can produce capsular phimosis and lens tilt, and postoperative. In this particular case, there's a postoperative refraction of 1.5 diopter. That is a hyperopic shift with the 4 because of lens tilt as well, minus 4 cylinder as well. And you can see this is a capsular phimosis which occurred in a postoperative. This patient had pseudo exfoliation as well, and because of that, there was a posterior shift of lens. There's another patient with the multifocal toric lens, again hydrophilic lens, wherein there was a folding of the lens still and posterior shift of the lens, and because of that, there was a hyperopic shift, and also the cylinder got induced. Again, this patient had a corneal burn. This is a multifocal toric again. You can see a corneal burn, and because of that, I had to suture the lens. Whenever you have a doubt We always sutured the incision, and because of that, there was an irregular astigmatism as well, and the patient was not happy. Again, hard brown cataract, you need to make sure the cornea is very crystal clear. One of the principles of the refractive cataract surgery to make sure the cornea is very clear. When you have a corneal edema like this, you can end up not only in a corneal edema, you can also have a cystoid macular edema. And because of that, the patient's vision dropped by about a few lines, and it is 6 by 18. So what I do is I use NSAIDs for all toric patients and making sure, and also use very good viscoelastics like Viscoat or Disco Whisk to make sure, and also the phaco modulation, the power modulation, like a cold phaco technique, to make sure that the cornea is clear irrespective of the density of the cataract. Again, the Rhexis tear, when you have a Rhexis tear, I would not suggest putting a toric lens, because you don't have the integrity of the bag as well, and you cannot guarantee long-term centration of this lens. And that's what has happened. A residual astigmatism because of this toric IOL is implanted in a Rhexis tear when the patient had an Argentina flag sign like this, because the patient had a toric thing. Make sure that the patient don't get toric lenses in such situations, because these patients can the toric lenses can shift over a period of time, and because of the lack of the bag integrity. Again, another patient with a large PC tear. The large PC tear, the toric IOL was implanted and it got decentered as well. If you have large PC tear, you have to make sure that you don't put a toric lenses, because this is one of the contraindications for a toric lens. If you have a small PC tear like this, then you can probably put a toric lens. In this case, I was able to put a toric lens. You can see here, this is a PC tear which has occurred here. You can see this particular area. There is also a residual cortex. You can see that, and you can see that I'm doing a bimanual IA. Once I do a bimanual IA, making sure that I use a good amount of viscoelastic, yes, yeah, good amount of viscoelastic like disco whisk, coercive viscoelastic, and dispersive viscoelastic as well, to prevent hydration of the vitreous, making sure that the anterior hyaloid is not ruptured. And you can see that I'm having an anterior chamber maintainer, introducing visco every time I come out of the eye, and then going ahead and putting a Technis toric lens in this case. Fortunately for me, I was able to just tuck the lens inside, and this is the 180-degree axis, the same axis as the size of the as the location of the incision as well, and the patient did very well. But large PC tear, my sincere message, take-home message, not to put this thing. Again, patient with a large PC tear, you can see, plan for a toric lens. The lens started tilting into the vitreous cavity, and you can see here, I'm trying to do what is called an anterior assisted levitation of the lens. And you can see here, once I did the anterior solution, we removed the nucleus. No toric for this patient, okay? Definitely not that, because this patient has got a large PC tear, but the capsular Rhexis is intact. I went ahead and put a multi-piece lens in the sulcus, and the patient did very well. So again, no toric lenses for these patients. Again, zonular dialysis. Again, another patient with zonular dialysis. Again, no for toric lenses, because the zonular dialysis, you cannot guarantee long-term centration of these lenses. I put a multi-piece lens, and even then the multi-piece lens also decentered, and not a toric lens, even a multi-piece lens also decentered in this particular case. Again, another important message I want to give is that when you have a patient with a toric lens, especially high myopes, I think myopia beautifully suggested as touched that point as well. When you have a large bag, please do not inflate the anterior chamber too much. When you inflate the anterior chamber too much, there's a possibility of the lens moving in the bag. So that can also happen. So all these patients, most of the toric patients, the majority of the rotation occurs within the first few hours, first 1 or 2 hours. So I always make sure that you keep the patient in your hospital, in your ward for about 2 hours, and make sure that you put the patient on slit lamp at the end of 2 hours, and make sure that you see the axis is it confirms with the axis of the location, whatever you have done intraoperatively. If not, you can go in and always put the patient back into the same position. So this is one important message I want to give, because these are the maximum rotation occurring within the first 2 hours, and I think it's important that you see the patient end of 2 hours, not discharge the patient like other patients, wherein you discharge the patient after 10 minutes. Here I keep for a couple of hours, make sure that at the end of the thing, see them on the sit lamp and confirm the access before we discharge. Thank you very much for the wonderful opportunity. I want to also give you a COVID-19 message. Stay home, stay safe, stay healthy. Thank you very much for the wonderful opportunity, the patient attention as well.
Thank you so much, Dr. Mohan Rajan, for that wonderful talk. And